Today my topic is effectiveness of homeopathic medicine in HIV patients. An open clinical trial we have conducted at different centers of Central Council for Research in Homeopathy. It is under Government of India. It is under Department of Ayush. Ayush stands for A for Ayurveda, Y for Yoga, U for Unani, S for Siddha, and H for Homeopathy. Next. It is better to give an introduction before starting with my study topic. So, Central Council for Research in Homeopathy is a premier organization conducting research in homeopathy in India. It is an autonomous body under Government of India, under Department of Ayush. We have 33 institutes all over India, institute and units all over India conducting various type of clinical research and fundamental research. Next. Regarding homeopathy, the conceptual framework of homeopathy is basically on symptomatic assessment rather than going into a particular diagnosis. So we accept diagnosis is very, very important for treatment purpose, but basic concept is symptomatic assessment of individual cases. The individualization concept and RCTs may not work together as we have inherent contradictions always. Because when we take individualization, that means you have to give the intervention individually. But in RCT, it is randomized. So there are certain area which we cannot agree, and the modern concept also are not accepting this our methodology what we are using for research purposes, but we are making into some sort of compromise. To keep both this individualization and RCTs in balanced form, we are using multiple intervention rather than a single intervention for such studies. And we are taking all this multiple intervention into a one point, that is effectiveness of homeopathic medicines. Next. And basically in HIV research right now what we are doing it with already existing homeopathic medicines. We are not giving any new medicines for HIV. Next. And all these medicines have reported action similar to HIV AIDS complexes. Are there medicines? Some medicines have reported to have developing oral ulcers, oral candidiasis. Some cases, some medicines have property of emaciations, weight loss. Some medicines have pneumonia, characteristic features. We are taking consideration of all these components and we are taking, according to that, we are taking all these interventions. Actually, certainly this is absolutely in contradiction to the existing medical practice where new diseases requires new medicine. Next. We have conducted several observation studies prior to our randomized trial, and we have published a randomized trial report on 1998 in British Homeopathic Journal. And in that report, we have pointed out that there is a certain changes in the CD4 level of PGL group. We had two groups. So this classification were that at that time what we have conducted, when we have conducted this trial in 1997, 96, 97 I think. So that time the classification of HIV was little bit different. Now it is revised. Next. To strengthen the evidence gathered in different observational studies and RCT, we undertook another study on viral load changes. So that we are going to present here. So we have added another parameter of viral load, that is one of the important parameter for progression of this disease condition. And we have conducted this study in two different centers. One is in RRI Mumbai, where I was the principal investigator, and another is in CRU's Clinical Research Unit in Chennai. Before going into the detail of this study, so just for the appreciation, the global estimate is 35.3 million in 2012. There were 2.3 million new HIV infections globally, and there was a definite decline of this infection due to conventional interventions. So previously The decline of 33% of the number of new infections from 3.4 million in 2001. Number of AIDS death is also declining. 1.6 is in 2012 and it was 2.3 in 2005. Next. So the present scenario of treatment is antiretroviral therapy, and this is the only targeted therapy, and it is only tested therapy all over the world, and WHO has adopted this therapy, and all over the world they are following all these antiretroviral therapies. Though it has prolonged the life of the patient, prolonged the quality of life, and reduction of opportunistic infection has also improved in antiretroviral therapy. But there are several adverse reactions has been reported. There are some reactions are very severe and some are very minor, like skin rashes. But there are certain conditions like Stevens-Johnson syndrome, it's a fatal disease, and cerebral hemorrhage. Then constant hepatotoxicity is also observed. There is a lipodystrophy. There is a cholesterol level, increase of cholesterol level. There are a lot of toxicities have been reported. A lot of adverse reaction has been reported with antiretroviral therapy. Next. Why should we develop an alternative to antiretroviral therapy? That is not actually acceptable, but we should think about that. One is the Boston's patient. Boston patient's cure became reversed. There is a stem cell therapy was applied, but that has been reversed. That recently it has been reported that patient turned positive. So, and this is a very costly affair, and you cannot apply to millions of people, those who are infected with HIV. And challenges in vaccination trials, we are not able to develop a common vaccine for HIV because of its mutation properties. Then toxicity and adverse reactions of ART. Then economic burden is very, very important in all over the world, especially in developing world. Next. Then there is a reported drug resistance. If the patient is not adherent to this ART therapy, there are reported drug resistance. And in long duration treatment, this requires intervention of many years. So that also has created this drug resistance. Then certainly viral mutation. And there is not an end to the treatment level. There is no curable things here. It is only viral suppression. So there is a first line treatment. Then first line treatment fails. Then it is second line treatment. So it is going on. Then we should think about delaying ART by keeping the patient's CD4 in a respectable level. So that is also very, very important. Next. Considering homeopathy, it is a proven system of medicine for various so-called incurable conditions. Certain incurable conditions, like certain surgical conditions, the so-called surgical conditions, homeopathy is very, very important. Then there is no reported side effect in homeopathy. Then it has a proven system of medicine for chronic ailments. So I already told you that we have conducted double-blind studies and open-label studies. So we have included these viral load parameters to this study. So we are going ahead with that. We have gone ahead with that. This study. Next. Aims and objective. Primary objective is the therapeutic role of homeopathic medicine checking or delaying the progression of HIV infection. Next. Secondary objective, compare whether the HIV viral load changes are relative to the changes in the CD4 level under homeopathic therapy. Next. To ascertain the changes in the physiological functions and quality of life amongst HIV infected individuals under this therapy. Next. And this primary and secondary objectives monitored by measuring the changes in the CD4 level and changes in the HIV plasma viral load, then assessment through WHO instrument and body mass index. Next. Ethical clearance was obtained from Institutional Ethical Committee for conduction of this study. This was an open label, observational, prospective, multi-center study of 1.5 years duration. Age group is 18 to 50 of both sexes. Next. An informed consent was obtained from the confirmed HIV patients prior to the enrollment of study. And conducting HIV research especially is very, very difficult task, especially in alternative medicine, any alternative medicines. There are many complications will develop, and that may create a lot of problem ethical issues. So one should have ethical clearance first before starting. Ethical clearance is a must for all the study, but especially you have to be very careful while conducting HIV research. Next. Inclusion criteria, the positive antibody test as per the NACO guidelines. Both sexes, the age group I already told you, 18 to 15 years. Then CD4 level count 250 and above. Because this is the guideline by the NACO. We cannot treat any patients below 250 CD4 level. Then viral load the same. Next. Exclusion criteria, undergoing any treatment, systemic treatment. VDRL positive we are excluding. Hepatitis B positive is also excluding. Active mycobacterium tuberculosis infection is also excluded. Continuing drug abuse, having taken any conventional antiretroviral drug also for the past 12 weeks. Pregnant and lactating mothers and below 250 level of CD4 level is excluded in this study. Next. So baseline and follow-up investigations, CBC, LFT, RFT, Manto, VDRL, X-ray, chest PA view repeated at the end of the study except in X-ray, VDRL and Mantos. CBC and LFT were repeated after 3 months, every 3 months. Next. Other investigation viral load assessment was done at the baseline at the end of the trial. Then body mass index was calculated at the base as well as at the end of the study. The impact of the intervention on quality of life was assessed. WHO QL instrument by patients. It is a self-administered instrument at the entry and at the end of the trial. So we have taken this from WHO. They have a Hindi version and Tamil version, I think Tamil version. So we have applied this instrument to the patients in local language. Next. Those patients who fulfill the inclusion criteria were enrolled for the trial. Detailed case history was taken. It is mandatory for homeopathic individualization. We have taken the case as per the guidelines of homeopathic case taking. Next. And after case taking, we have repertorized. There is a process called repertorization. That is a computerized program is developed. All the homeopaths are using this type of methodology. So we will feed all the symptoms, that what are the symptoms we are, that is important for homeopathy perspective. So then we will get an outcome of a group of medicines. So again we will assess with our medicine textbook, then we will finalize, we will select this medicine. And we have potencies, the strength of the medicine. So it is a different term. So potency, we are using it 6C to 10M potencies. There are different potencies available in homeopathy. So we have restricted this 6C to 10M potency. "90 patients of various categories of HIV infection as per CDC classification were enrolled in this trial. Out of 90, 13 patients lost to follow-up and dropped out from the study. Next. 5 patients withdrawn due to deficient post-interventional viral load testing and CD4 assessment owing to delayed follow-up reporting. Only 72 patients were analyzed who have completed the required follow-up of 6 months. Next. These are the results. Demographic characteristic, total patient N is 72. I think I don't have to explain anything. This. So 21 male and 51 female. Next. Low income group is 65. Middle income group is 7. Next. These are the intervention we have used. I already told you we have not taken a single medicine against HIV, and we have taken as individualization. So these are the frequently indicated medicine has come in this study, and this Calcarea carbonica, Lycopodium, Nitromuriaticum, Phosphorus, Pulsatilla, Rustox, Scipia, Officinalis, and sulfur. And out of all these medicines, though it was an individualization. Lycopodium clavatum, there is a fungus. Lycopodium clavatum was prepared from fungus in homeopathy. So this medicine has shown statistically significant result both in viral load and CD4 level. This is the only medicine has shown statistically significance out of this many medicines. Next. And WHO QL BREF, and we have found actually, except in social domains, all the domains were statistically significant. In physical health, they have shown well-being, then psychologically they are also improved, environmental also they have shown their improvement, only social has no difference at all. Next. Then results in CD4, we have not observed any changes, marked changes. Though the difference is very minimal, but there is no statistical significance in the CD4 level, but viral load has shown some sort of statistical significance. Next. So these are the result in short. Viral load has shown significant result. CD4 has not shown any important significant result, and BMI also has improved, it has shown statistically significant result. Next. Still, these are the unresolved questions in our trial. How does the mutations can be tackled in homeopathy system? We don't know. We are not gone to that level of study. Are those medications effective in killing virus? Whether it is killing or suppressing the virus, we don't know. How does the ultra dilutions of homeopathy work on preventing the viral replications? We don't know this. Actually, this study on ultra dilutions are going on in our fundamental research. We have a collaboration with, not in HIV, and we are in collaboration with the Bose Institute, Kolkata. So we are doing it, that study further. Next. The study has shown significant reduction in the viral load volume. No positive shift was observed in CD4 level. There were significant changes in the QOL and BMI. The study has underlined the effectiveness of intervention, this homeopathic intervention, which required to be duplicated using a control arm in large sample size and on a wider platform. Limitation of the study, certainly this is an open label trial, and a lot of bias can be contributed to this result. Multiple medicines rather than single medicine. This is not limitation of the study in homeopathic perspective, but in someone from outside looking into this study. So we cannot finger point one medicine for this particular condition. And the follow-up period was very short term, it only was 6 months follow-up. Next. So we are thankful to Dr. M.S. Menon and Dr. Jayanti Shastri. Dr. Jayanti Shastri is the head of the Department of Microbiology in Nayan Hospital. She has conducted this viral load testing, and Dr. M.S. Menon was a renowned HIV expert who is into that WHO, and he has supported this study, and our statisticians, all research collaborators from CCRH and our different units. Lastly, we are greatly indebted to our patients who have enrolled in this study. Next. So thank you so much. And we have our journal also. It is IGRH, Indian Journal of Research in Homeopathy. It is an online access, free access journal. And you can contact us rrihmobi@gmail.com. Our website is ccrh.org. Thank you. Thank you so much. Any questions, please?
I have a few questions. First question is, what was the rationale behind choosing your mixture of the homeopathic medicine?
It is not mixture. We are giving individualized medicine.
Individualized medicine.
Yeah.
So
It is rationalized. Rational means we are taking that case. So there are certain criteria for selection of homeopathic medicine that is called simillimum. So if you come to me, then we will ask a lot of questions regarding your actual condition, disease condition. This is a holistic approach as we are practicing all complementary system, but our approach is a little bit different. So if you are coming to me, we will ask a lot of questions regarding head to foot, what are your complaints, and its aggravation and amelioration, its modalities, and your desire, aversion, intolerance. These are the important things. Whether you like sweet, I may give an example. This is whether you like sweet, salt. These are all contributing to our medicinal selection. So again, we will take the mental features. Suppose you are depressed. Suppose the HIV, almost all the HIV patients are depressed. we are not going to consider that depression is one of the important symptoms because it is a disease symptom. It is a shock created by HIV. So you cannot consider that symptom. But if you can giving this depression with something else other than HIV, those HIV patient is suffering from depression because of their marital problem, marital discordant or something like that, then we will take into consideration. So these are, I am giving just an example. So all these mental features contributing to the selection of the medicines. See, you cannot compare with the antiretroviral therapy and homeopathic medicines. We cannot have a control like this.
No, his question is, can you combine it?
Combine. Yeah, we do that. We do that. We do that. We have conducted one research in Delhi and with the NACO. We have conducted and we have yet to publish that report. And we find that in homeopathy plus ART group, there is a combined group, homeopathy and ART group. We find statistically significant better result than only ART group and placebo.
It is NACO approved.
Yeah, it is NACO. It is a NACO collaboration study.
This combination treatment is available in the ART centers?
No. That has not yet published. It is under process.
It is not available in the ART centers?
No, it is not available. Sir, we are facing a lot of problem with the different ART centers also. Because actually the people basically in charge of ART centers are modern physicians, modern physicians. And they are...
NACO can accept you.
Yes, sir. So what I am telling is, we have approached this local NACO people. They refused. Then we have approached the highest authority. Then we got, okay, you start with your project in one center. Okay. So we have started that project and we have completed. Then we have prepared another protocol. Another protocol, it is submitted to the NACO. Last 1 year is pending. Last 1 year we have been waiting for the reply. And NACO and ICMR has to approve. Now actually on this project also, we tried to publish in an international journal. This is what I faced. And they refused to accept unless it has to be certified by the ICMR people. So that is the rule. Whatever the research you are conducting in alternative medicine should approve through ICMR. Then only it is acceptable to any international journal, peer-reviewed journal.
But in ICMR, you people also there?
No. We are in a different, just like ICMR.
I know, ICMR, the homeopathy people are also there.
No homeopathic people, sir.
Yes, they are.
No, maybe they are working for in some other field, not in as a homeopathy.
No, in the administrative positions are there.
Maybe, but that is not it's a separate issue, administration. But we are tackling it actually now. We have more and more collaboration with ICMR and NACO. And we are going to develop one protocol in combination with this.
Is an umbrella for Ayurveda, Siddha,
All. Department of is meant for developing Ayurveda means alternative system.
First of all, wonderful presentation.
Thank you, sir.
I would like to congratulate upon, because the topic is timely, very timely, and the social stigma is there. So I would appreciate that. I have got one question, one query. That is, don't you think that the follow-up period is very short? Because the HIV positive, after 10 years usually it develops in 2 years. So have you come across any case where the AIDS developed AIDS couldn't reach the death?
Yeah, I will tell you.
Number one.
Yeah.
And number two, 6 months follow-up is certainly, I think, is a short.
So we have agreed in that study also.
To make inference.
Yes. So that short.
Homeopathy is a magic, I know. It produces magic.
And let me answer. Sir, actually this 6 months period we have already, it is a short period, but we have to have some restrictions on conducting such research. And because above 250 and that criteria for CD4 level is also a little bit critical, above 250 only and above that.
Because I have seen, I have also doing this through the Ayurveda.
Yeah.
I have seen HIV to maintain 100, 250. Sometimes when you are keeping on giving that medicine, and then it becomes resistant. So unless a little follow-up period is long,
Yeah,
you cannot assess your medicine.
Yeah, I would like to tell you, sir, we have in regional research into homeopathy, we have 4,000 cases. We are conducting research parallelly and we are having OPD also, separate HIV OPD. And we have cases without ART, at least 30 to 40 cases. I'm not telling that big cases, chunk of cases, but we have 30 to 40 cases not on ART for the last 15 to 20 years. So still we have that type of, we are able to maintain that group of people. And another group, we have referred our cases because after, if it is not responding to our medicine for a long treatment, for suppose they have been under treatment for 10 years, and after that they are not responding to our medication. So we should refer, especially in ethical consideration, we should refer this patient to ART centers, and we are referring those patients to ART centers, and again they will come back to us to continue with homeopathic medicines. So such people are there because they are continuing with ART plus our homeopathic medicine. In that cases, what we find that certain toxicity like liver toxicity, all these things we can manage easily, especially in skin. Homeopathy is one of the best medicine for skin diseases, and especially we are managing with because recently I had one case of Stevens-Johnson syndrome. That if you search in the net, you will find that what is the critical nature of that disease condition, Stevens-Johnson syndrome. We are able to cure that condition without any relapse or without any sign of that conditions. So that is all already going under publication now. It is submitted to one peer-reviewed journal. It is under publication. So we are managing such type of toxicity also with homeopathy.
Dr. Muralidharan, I'm sorry. It's a very challenging, trial which you are conducting actually. It's very relevant to the modern world. I just would like to know the individualness. I want to just understand. Will you choose the number of combinations you will be choosing based on the individual input, or the dosage will be selected based on that? Number two, the CD4 level is not coming down actually as it's probably maintaining stable. That means it is a managed. This is managed.
Individualization means actually we are taking the single medicine, not the combinations. Suppose lycopodium has given to that patient only that time of intervention. So we have continued with the lycopodium, that too in daily doses, not in daily doses. Hardly we are giving 1 or 2 doses per month. Other patients, same way we are doing it. All the patients, it is suppose some other medicines, Netremure or Sepia, all these medicines are individually selecting and we are giving to that particular patient only. So that's why we have conflict with the randomization process, and because it is individually. Suppose you are getting one medicine, means you will be getting a single medicine of that, not the combination of some medicine. Combination is against homeopathy basically.
So in order to understand the modern way, that all the 15 or 20 components which are essential for maintaining HIV.
See, it is
only any one
of this medicine, not for all HIV patients. That's a complication in homeopathy. So that is a complication in homeopathy. That is our limitations also. But it is we have to stick with our principle also. We cannot, if you are changing the principle, means it is not homeopathy. So that's why we are facing some sort of problem, and we are actually trying to develop some protocol where we can point out some particular medicine. So we are working on that level now. Suppose in osteoarthritis we have some medicine called Restox. We are doing it with Restox only. So in ulcer, venous ulcer, we have certain medicine. Calcareous floor is one of the important medicine. So we are trying to make calcareous floor and venous ulcer. So we are trying to make such studies also. But this is actually, we have to show that first thing is viral load and CD4, whether it is increasing with the homeopathic medicine. So our one component is homeopathic medicine, intervention only, not the individual medicines. We are not concerned with the individual medicines, but it is only one medicine. But out of this, we got a statistically significant result both in CD4 and viral load, that is lycopodium. So still we are trying it. Lycopodium is best medicine for asymptomatic condition rather than symptomatic condition in HIV. What we are experiencing in our clinic.
So
May I ask you?
That is out of your experience.
Yeah, this is out of our experience.
I wonder, you had with this well-performed study, you had an opportunity to have a control group. I cannot understand, because you have 72 patients and you have followed them for a long time. You never know what had happened without this homeopathic medicine. You have no idea what had happened. Could be exactly the same results. But if you had a control group of 72 patients with placebo, you could tell us that there is a difference. I don't
Yeah,
know
actually-
why you didn't take that.
Actually, we have started this protocol with the control group.
Must be much more.
So actually,
interesting
control
because-
group, what is the problem with actually then conventional system? Our consultant was telling, you go with the ART as a control and homeopathy. So that we didn't agree because ART is a targeted therapy. We know that it has what effect on that, but we don't know what is the effect of homeopathic medicines. So we have rejected that proposal.
But-
Then we have gone with placebo. Placebo actually ethically it is not advisable in HIV.
Ethical committee.
So in HIV, any study, placebo, earlier actually from the very beginning it was conducted with placebo, but now in last 5 years I think.
But did your patients, did they have ART on this, at the same time? They have the other medicines also, or not?
Pardon?
In your study, they didn't use other medicines, these conventional medicines, ART, they didn't use.
Question is that did your patients whom you have selected, did they had this antiretroviral therapy?
Only homeopathic medicine.
Yes.
They were under homeopathic medicines only.
So why would that be an ethical problem to give a control group
No,
placebo?
actually that's why we have taken actually above 250 level is a safer level for any intervention. So there is no ethical objection from the ethical committee also.
So the same group would have been for control also, the same protocol would have used.
So that's what I'm telling, we are unable to give placebo. They are objected, the ethical committee has to approve this protocol. They are objected for this placebo trial. So that's why actually at the beginning we have started, okay, let it be like that. So we will go for an open label trial, we will try to find out any changes in the viral load. Now we have submitted this new protocol to NACO and ICMR and we are waiting to get, there is a control trial. We are waiting to get, actually I think this year we will be starting this control trial.
Suppose if the patient, the patients you have recruited, and if you find that their viral load is not coming under control, how were those patients managed?
See, if it is not, if we are not able to control this such cases, we are referring this patient to ART centers.
You were actually discussing.
Yeah, definitely. We have good mechanism. Actually, in Bombay, we have a very good mechanism. We are getting a lot of patients from the JJ Hospital, KM Hospital, Cooper Hospital, and this Dr. Jayanti Shastri. She is one of the best doctor because whatever she is not able to control any cases, treat any cases. She is referring to us mostly. And we have another ART center that madam is well versed with our treatment. So she has referred that, I already told you that Stephen Johnson syndrome case to me. Because they were unable to treat that cases in your in that their setup. So the patient was getting worse and worse. So that's why as a trial basis they have come to me. So these are actually both systems can complement each other. I am not telling that you take only homeopathy or only Ayurveda or only, but if you have come together already that yesterday's slides we have shown that there is an integration of all the system is very, very important for saving the life of the patients. That's very important than any other research.